discussion and energy. It just seems that it's a fabulous sessions that were organized and a fabulous discussion that has come up, and I'm sure people will continue to talk about it. We will now start with our third session, and again a very interesting, more focused on mostly leukemias. And so the first speaker we have is for immunotherapies for pediatric leukemia, and this will be given by Dr. Samina Afzal, who's presently working as a pediatric oncologist at Sheikh Khalifa City Medical City Hospital in Abu Dhabi. She is also an adjunct clinical professor, post with Mohammed bin Rashid University, again UAE, and she has been trained and worked at Great Ormond Street Hospital as well as Sick Children Hospital, Toronto. So, Dr. Samina, aaj
Assalamu alaikum, and thank you for providing me this opportunity. It's definitely a lot of immune therapies are new for us. And so I will try to grab it in 30 minutes. It's quite difficult because if I'm presenting leukemia or Hodgkin lymphoma, 90% of the things we know previously, but it's a bit of new for all of us. So it will, if it takes slightly longer, I'm sorry for it. Anyway. So when you are treating a children with a cancer, traditionally we are using the cancer therapies, and the most of them, they can have side effects. But when you go to the immune therapy, you may have less side effect compared to what we are getting till now for the last many decades. There are many children, adolescent and young adult with B cell leukemia who are cured with modern risk-adapted chemotherapy. But the outcome of 5 to 10% of the children who suffer relapse is still quite poor. Excess toxicity, lack of efficacy have prevented efforts to intensify further chemotherapy among these children. This is, if you look over here, this is the introduction of the 100% if you look at the malignancy. Most common are the leukemia. In the leukemia, they are more prominent in this age group. As you passes off, the lymphoma become more prominent with the older age group. With the chemotherapy agent used in childhood leukemia over the year approved by FDA, if you see over here, it's long back. So nothing has gone new for the last many years. Then imatinib came in 2013. For the last 10 years, a lot of progress have been going on, a lot of studies have been going on, but we haven't got anything that can change, that can bring a revolution in our children to cure them. This is here, the outcome of the newly diagnosed leukemia. If you see, I usually sometimes show this to the parents as well, just to tell them that they are in an era that we can save these children. So this is over here many years back, and it was persisting over here for the last decade. Definitely, the cure of the children have been improved a lot with the leukemia. But again, outcome remains poor for the pediatric ALL that is refractory or in second or great remission. So these are the children that need more attention, more work to be done, and how to see how we can improve cure in these children. What are the risk factors for relapses in our children? It could be clinical, the age of the patient, white cell count, CNS status, timings of the relapse. It could be the response to the treatment. Now, for the last 1 decade, we are using MRD. MRD has been especially helpful to stratify our children, standard risk, high risk, very high risk. Then we come to the genetic. It could be hypoploidy, hyperploidy. So these are the certain factors that we have to look when a child has been relapsing. Again, the clonal evolution of the relapsed leukemia. It could be intrinsic drug resistance. It could be acquired drug resistance. It could be evolution from ancestral leukemic cell, or it could be genetically distinct leukemia at the time of the relapse. So this all have to keep in mind when we are treating a child with the relapse. Again, if you look over here, this is a genomic landscape in BALL 2021. These are the lot over there. TKI, standard of care in Philadelphia, being tested in ALL. No standard targeted therapy for other subtypes. So the importance at this point to look in, instead of intensifying the chemotherapies or more risk stratification, we have to look how we can look further into it. Then a revolution started in the world of the leukemia, and we are getting now a lot of the things that can be helpful. We go one by one. It could be CAR T-cell therapy. It could be inotuzumab, or it could be blinatumomab. I go through a bit of these just to understand what to do with them. This is just a journey of the advances in the immune therapy. Or this is 50s to you, the here coming here, auto BMT, then you come to the allo BMT, then you have the donor lymphocyte infusion, then you have got brentuximab, blinatumomab, and CAR T-cell therapy. This is how the advances in the immune therapy are going over the last few decades. Then what we are treating for, for example, target to the tumor are the chemotherapy in auto BMT, monoclonal antibodies. Target to the host, we use this. And the target to both tumor and the host, we are in the era of this, that we use blinatumomab and CAR T-cell therapy. So what is Bluna? So the attention is being shifted toward the novel approaches, including several immune-based therapies, blinatumomab, inotuzumab, and this CAR T-cell therapy. This is the FDA-approved product. So recent effort to intensify treatment with augmented consolidation therapy or the higher dose of oral methotrexate. We all know that there was a randomization in the ALL 0932 to use either 40 milligram per meter square of methotrexate versus 20 milligram. It has not worked of these. So these efforts have been made, but nothing has been fruitful till now. What is Blina? If you look over here, Blina, it is composed of two single chain variable antibody fragment. This is here, you can see, that are connected by a flexible linker to, I would say from here inside, I can't see well, that are connected by a flexible linker to the CD19 receptor and with the CD3 receptor on the T cell. So this is how Blina looks like over here. How Blina works. That is very important to understand how these medications are working, because if we are dealing with this I already informed you that this is the CD19 receptor on B cell. This is the CD3B. Yeah, this is the CD3 receptor on the T cells. And this is over here. When this attachment goes, the T cells get activated. And there is an upregulation of the molecule CD25 and CD29, CD69 on the T cells. This leads to the release of the perforin and granzymes. And then this is, you can see over here, this perforin molecule, they polymerize in the presence of the ionized calcium, and they form a pore in the membrane of the B cell. These pores allow these granzymes to enter, and this cascade lead to the tumor death. So this is how it works. This is the attachment of this is here, Blina works, go to the activation of the T cell, granzymes are released, they come into the B cells, and this cascade go to the death of the tumor cells. So Blina is a biphasic T cell engager antibody that construct targeting T cell on B cell lymphoma. Study, there is a first, initially was the phase 1 and 2 study. Study evaluated the safety, pharmacokinetics, recommended dosage, and potential for efficacy of Blina in children with a relapsed refractory B cell. You have to keep in mind that when we have treated these children, they can have multiple treatments in their lifetime. It could be various chemotherapies, and it could be allogenic transplant as well. The study enrolled children less than 18 years old with relapsed refractory B-cell leukemia. In phase 1 study, the dosage was checked, and phase 2 study, 2 cycles were used with the 6-week interval. 4-week Blina was given with the 2-week interval, and then second cycle. Stepwise Blina dosage was increased, initially 5 microgram per meter square per day for 1 week, followed by 15 microgram per meter square per day that we are using recently over the rest of the days. Among patients, 5 by 15 microgram, 39% achieved complete remission within first 2 cycles, with the most responders achieving complete MRD responders. Phase 2 study of pediatric patient with a relapsed refractory disease demonstrated a 39% complete remission within 2 cycles of single agent Blina with minimal residual diseases negativity in 52% of them. So these are the results. So this is very promising to go further with the blinatumomab in our further studies. This trial, to the best of the author knowledge, was the first trial in pediatric, demonstrated anti-leukemic activity of a single agent, blina, with complete MRD response in children with relapsed refractory B-cell. Blina may represent an important next treatment in children. So this was the step that forward. Although adult studies were going before that, but this was the first children's study that moved forward toward the blina. Infant, I will not go much about the infant. I was not knowing that Dr. Asim talk is after me, so I've entered it, but I've tried to skip it a bit because definitely it's covering a bit. Infant with acute lymphoblastic leukemia diagnosed in first year of their life have a poor prognosis. We all know that children between 1 to 10 years are standard year, less than 1 year infant, they generally doesn't have as good prognosis, and then more than 10 years are high risk. Especially the prognosis is poor for those who have KMT2TA rearrangement. The event-free survival is less than is 36%. I will skip it a bit, but I will just show you what has been done in the new trial. After induction, they use the blina cycle, and what it has come toward it. 10 serious side effects occurred that is not very significant: infections, fever, hypertension, vomiting. More than 90% of the patients were MRD negative or had only only very low level of leukemic cell after blina therapy. After median follow-up of 26.3 months, survival was 81.6% in this study. So I will not touch it more because Dr. Asim is going to do. What we are going here is I just show you what is the standard of care we are using now. In infant with the KMT2A rearrangement, we check if it is positive or negative. If it is negative, we continue with the chemotherapy. If it is positive, we give 1 cycle of the blina and then MRD assessment again. Where if it is positive again, then it has to be discussed with the transplant team, what is the further. However, we had a child, I will just tell you one case. I will tell you the cases in between. We have a baby who presented with 4 months of the age with a white cell count of 1.2 million. Very high white cell count. He had KMT2A rearrangement positive. He had a good response at the day 7, but the thing is that we have not only given the steroid, we give 1 cycle of the COP as well, because the white cell count was very high and we were scared of having the complication. He came out of all those complications very well, and post-induction MRD was negative. We gave 1 cycle of the blina. His MRD was negative post-induction, but after discussion with the international teams and everything, they think that no, white cell count was very high, age was 3 months old, and they prefer to take it for the transplant. He's 6 to 9 months post-transplant. I cannot share his picture, but it looks wonderful. So the thing is that the blina did a very good job, and the child went to the transplant with the although minimal residual disease was negative prior to the blina as well, but definitely it maintained the remission and the child went very well for the transplant. We have another child now who is 3 months old, have a white cell count of 360,000, same KMT2 rearrangement. We did the MRD post-induction. Post-induction, MRD was negative, but we gave 1 cycle of the blina. It's very, very rare that MRD came positive post-blina. So now there is a discussion going on that people in the transplant team thinks that transplant may not be as helpful as CAR T-cell therapy in this situation, but we have just repeated the MRD because it was found to be extremely rare that the child did very well, and why it will come. There was no illness, child is thriving well. So these are the things that patient, like it is not, it's a protocol, but it's very individualized with the patients as well. So the effect of the post-reinduction therapy consolidation with blina versus chemotherapy on disease-free survival in children and adolescents in the first relapse So the after infant, the next study of the COG, this is phase 3 study for the children, comparing the blina with the usual chemotherapy in the relapse. The post-reinduction therapy in high and intermediate risk post relapse of acute lymphoblastic leukemia in children and adolescents demonstrates superior efficacy and tolerability of blina. So this was the protocol. You can see, I will not go too much, but you can see over here that intermediate and high risk after induction, they were giving 2 cycles of blina, whereas the chemo was continued. This was in the intermediate and high risk protocol. Patient aged 1 to 30 years with intermediate or high risk in BALL in first relapse to receive either 2 cycles of blina or 2 cycles of multi-agent chemotherapy. The study was terminated early by the Data and Safety Monitoring Committee, giving the superiority of blina arm after 2 years of disease-free survival. This you can see over here, 2-year disease-free survival of 54.4% in blina arm versus 39% in the chemotherapy arm. This is the overall survival, 71% versus 58% in that arm. Blina is well tolerated with cytokine release syndrome and neurotoxicity as the most common side effect. The risk of the CRS is related to the disease burden. The more the disease burden, the more, but this is not true for the neurotoxicity. I will just skip this case. Prior blina therapy is associated with favorable outcome after allogenic HST in pediatric patient as well. So this is the standard we are using for the relapse protocol. High risk, low risk are continued here. High risk, we are giving their 2 cycles of blina, and then we take them for the transplant. Whereas low risk, depending on MRD negative and time for the relapse, they continue like this in the maintenance cycles. So this is the standard of the care after the termination of this study. Blina as a bridge to further therapy is in cases of overwhelming toxicity in presence of pediatric ALL. Blina was given to pediatric patient with ALL in the setting of overwhelming chemotherapy associated bacterial and fungal infection. So it can be used in the patient in bridging. We have a 5-year-old girl who had acute lymphoblastic leukemia standard risk, and her MRD was high after the induction chemotherapy. We started her on intensive consolidation. After day 29 of intensive consolidation, she got high-grade fever, and after 5 days, typical fungal workup was done. And she had a fungus not only over the time of the 6 weeks, she had skin lesion, she had lesions in the liver, lungs, spleen, muscle, any part of the body except brain. She had lesions all over the body. She remained in the PICU almost for 6 weeks, and with a very high procalcitonin. Definitely, when she came out of all these crises, intubated, ventilated, we were not able to give her the chemotherapy. Chemotherapy has been toxic. When she's out of the crisis, we gave 1 cycle of the blina. Her MRD was still positive when we started her on the blina. Post-blina, she had MRD negative, and her organs have been much recovered compared to what was the initial stage. Her kidneys, liver, spleen, everything. So it was very successful to give her chemotherapy because chemotherapy was on hold for 2 months already because of her fungal infection. So it can be used as a bridge for the children who have a significant fungal infection, and then they continue accordingly. So Children Oncology Group then came to the phase 3 trial, investigating blina in combination with chemotherapy in patients with newly diagnosed standard risk acute lymphoblastic leukemia. This is again, you can see, don't go too much in the protocol. They have added 2 cycles of the blina. In addition, so we all know that oncologists, we have consolidation, interim maintenance, delayed intensification, and IM2. So they have added 2 cycles of the blina over here. And these cycles are given not consecutively, but with a break of this. So what happened, the study has been closed because the blina arm have shown the significant superiority. The blina randomized arm, patient number 718, have 3-year event-free survival of 96% compared to 87%. And I will just skip it. So Blina has been a standard of chemotherapy now, except in some genetics that are favorable. So we are using it as a standard of risk, and the study has been closed for accrual by COG. I will take a bit of 15-20 minutes. It's okay because this topic is very extensive. Yeah. So then we come to the ENO. Inotuzumab is an antibody drug conjugate composed of humanized IgG monoclonal CD22 targeted antibody. This is the second immune therapy that have been discussed now. How it works over here. ENO is a humanized anti-CD2 monoclonal antibody bound to a toxic neutral product, keliciamine. So you can see over here, this is the bond over here. It gets internalized into the cytoplasm. Keliciamine moves to the nucleus, binds to the minor DNA group, causes break in the DNA stranded. You can see this was the inactive. It gets activated, go to over here, and leading to the cell death. Again, there is a phase 2 trial of inotuzumab in children and adolescents with relapsed and refractory acute lymphoblastic leukemia. The results came quite promising. Yeah, this over you are seeing, number is 48. This is the event-free survival, 28% versus 96%, and over survival has been improved as well. I will just skip through it a lot. So this led to a COG to open another trial that in high-risk patient, should be introduced with the 2 cycles in the protocol. This you can see over here. Block 1 and block 2. The only difference is the rest of the chemotherapy is same as high-risk patient. But second part of the delayed intensification was not given with this cycle 2. But again, what happened? This has various safety. It has been various amendments in the study, and antimicrobial prophylaxis was added, and risk of the sinusoidal obstruction syndrome happened in this protocol. So study have been closed, and 2 cycles of the Blina are standard, not in the study, have been introduced. Potentially at 3rd cycle, COG is thinking on risk and response data, because adult data has shown a significant improvement in ALL after getting the 3 cycles of Blina. ALL 1732 did not yet identify tolerable regimen to incorporate. COG is redesigning the regimen. When it reopen, it may have 2 to 3 cycles of Blina. Plan for experimental arm of ENO is not yet formalized. So can I continue CAR T cell? It's okay. Yeah.
Yeah,
So-
you have like 2 minutes for CAR T cells.
This topic was very difficult to bring in 25 minutes. So CAR T cell therapy, very high risk ALL is defined as a persistence of residual disease after consolidation therapy. Patient with MRD more than 0.01 at the post-induction were doing very well compared to patient with the MRD high. This is the first drug approved, CAR T cell approved by the FDA. This is, you can see 2017, it led to the approval. A bit of the knowledge about the T cell is how they work. They work, signal 1 is the recognition. The T cell receptor recognizes the antigen on antigen presenting cell. Second is co-stimulation. CD28 binds to its legend on the antigen presenting cells. So this is how generally T cells are working. This again, you can see, this is the T cell receptor, antigen and binding. T cell binding to MHE legend causes downstream of the CD3. CD3 is a transmembrane molecule over here. This is how the T cells are working. You can well see over here that CD19 is present all over the cell from pro-B, pre-B, immature, except on the mature B cell. So the target of the CD19 is selected in the CAR T cell because of this reason. What CAR T cell do? CAR T cell recognize specific antigen on the tumor cells, resulting in their activation and proliferation, eventually resulting in significant and durable destruction of the malignant cell. CAR T cells are considered as a living drug because they persist in a body long. They are generally created from the patients of their own blood. This is, you can see over here, this is the T cell receptor, this is the CAR T cell, and this is the tumor cells. I will show you how it is working over here. This is again anatomy of the CAR T cell. This is the antigen. This is the extracellular antigen binding domain you can see over here. This is the hinge area of this. This is the transmembrane area. This is the intracellular co-stimulatory domain. We usually use to either CD28 or 41BB. 41BB is having a longer persistence in the life, so it is preferred over here. Then this is the whole anatomy of your CAR T cell. How it works.
Dr. Samina, if you can just wrap up,
Okay,
because
5 minutes.
today's
5 minutes.
namaz time, the Jummah, so
Yeah.
this has to wrap up.
Yeah, wrap up. It was a very difficult topic too. So anyway, so how it is working? So this is the CAR T cell, and how the message go? We through the genetic. This is, you can see over here, that for this they use when the CAR T cells are collected, they go through a genetic process in which the lentivirus is used. The lentivirus has got the genetic information for CAR T cell, and when it is going to the T cells, it goes to the translation, transcription, and these you can see are receptor produced.
Printer.
When they go further to the T cells over here, the tumor cells, when they found, this is how they cause the death of the tumor cells. I will just skip that region over here. So this is the final one. As you can see over here, that the leukapheresis have been done. Secondly, as I told you, that the cells are collected, and these cells go to the genetic modulation using a viral vector, for example, a lentivirus. This lentivirus is then go inside the T cell. After going through the translation and transcription, these are produced on the cell surface. They go to the CAR T cell, undergo expansion, and then chemotherapy to make the patient available, and CAR T cells are reinfused to the body. These CAR T cells identify the cancer cell, leading to the center death. So this is again, this show all the receptors on the surface of the CAR T cells and all that. I will not go in details of that. So anyway, these are the few therapeutic modalities that have been working now. Inotuzumab is not a standard of care. No, CAR T cells has been used in even in people who are interested to know. Stem cell center in the UAE is giving the CAR T cell therapy as well, and adults they have given a lot. In 11 children they have used as well, because sometimes it's difficult to send patient to the UK or America, those who can afford it. Blina has been very difficult for us to use. Definitely it's insurance issues, but for the local patients and the patient who get the finances, we are using Blina in these patients. So generally, these all treatments are a very good hope for the patient who were relapsing, and because of the intensive chemotherapy, it was more like a toxicity, and transplant has reached the image that multiple things were not helping in it. So future seem much brighter in children with relapsed acute lymphoblastic leukemia. Thank you.
Thank you. Thank you, Dr. Samina. So our next speaker is Dr. Professor Asim Balgami. Professor Dr. Asim Balgami is the Professor of Pediatric Hematology Oncology and Associate Dean for Clinical Affairs and Chief Medical Officer at Aga Khan University, Lahore. He is the scientific Karachi. Sorry. He is the scientific committee chair of SIO. He has been served as the president of PSPO. Recently, he has been working within the Paediatric Oncology East and Mediterranean group. His main areas of interest are childhood leukemia and lymphomas. Thank you, Dr. Asim.
Okay. Assalamu alaikum, everyone. So, Samina really made my life easy, because a lot of things I was going to talk about, she's explained it beforehand, which really makes it easier for us to go through the clinical results of those agents in there. But we're going to talk about leukemias in infants, and I was asked to talk about something new. Right? There's not much new. Right? So we're going to start off with, first and foremost, I have nothing to disclose, no conflicts to disclose. I just don't have the slide. So this is my disclosure here. So again, what we want to talk about first is infant leukemias. There are certain features, and we've heard them today earlier on also in other talks as well, is that infants present with much higher disease, much higher risk disease. And these are patients, these leukemias have your standard common logical high-risk disease, high white count, CNS disease, hepatosplenomegaly, leukemia cutis. So they present with bad disease. And if you see these kids, when they come in, it's really scary. And then you've just got to run in and jump and take care of them. They also have, ALL infants have a far worse outcome than older children, far worse. AML in infants has an outcome that is similar to older children. The issue that comes in is supportive care in these patients. And that is where, particularly in LMIC, you see a lot more sort of lower survivals and a lot more deaths, resulting in poorer outcomes for these children. But in general, their outcomes in high-income countries, in centers of excellence, is similar to that of older kids. Now, this is just looking at the KMT2A, the MLL gene that is there. It's called a promiscuous gene because it has multiple partners, 94 identified partners. The common ones in ALL are these ones that are shown in here, and the common ones in AML are some of those that are shown down here. And this is just the karyotype showing the translocation between 4 and chromosome, the long arm of chromosome 11. And this is just a break apart fish that is depicted over here. In ALL, the 411 translocation is the most common. The AF4 KMT2A translocation is the most common. 48% of infants have that. Others are also there. 911, 1119, X11, multiple others that you will see. And this is just a depiction of the breakpoint. There is a breakpoint cluster region that occurs right over here. And this is where the break on the KMT2A gene occurs. And then the fusion partner then joins up at this level over here. So this is the genetics of the function of the ALL. Now, this happens in utero. Right. At some point during intrauterine development, this translocation occurs, and the leukemia often generates, and I've seen at least 2 patients who I've taken care of where they were referred to us directly from the labor room, just post-delivery. Has a very short latency period as opposed to 1221 translocation, RUNX1 ETV6 translocation, which has a somewhat longer, that is also intrauterine, but has a longer latency period and presents around 3 years of age. The only other time that you see KMT2A is with topoisomerase 2 exposures. So secondary AMLs, post-etoposide, you will see these as well. There are certain SNPs, also genetic predisposition, that maternal genetic predisposition that correlates with an increased risk of infant leukemia, but nothing much more else. So again, as I said, infant ALL is bad if it has the KMT2A rearrangement. If the KMT2A is germline, which happens in older infants, so beyond 6 months of age, their outcome is actually closer to those of non-infant ALLs. In AML, the impact of KMT2A is much less clear. 119 may actually have a better prognosis. 1011 may have a worse prognosis, but either way, the treatment is the same. It's with the AML standard ADE therapy, and this is what I was showing over here. The only other non-KMT2A rearranged AML is acute megakaryoblast leukemia, acute megakaryocytic leukemia in non-Down syndrome children, which occurs in infants very often when it occurs. It's a rare disease. And in there's a 122 translocation, which involves these genes that you see in here. So this is the only really other purely infant leukemia that is seen. Treatment for AML is the same, ADE related, and then, based on that, MRD status, cytogenetic abnormality, and then availability of donor, etc., are the things that are going to be prognostic. There is an increased incidence in infants of acute and long-term toxicity, and this is really because of the changing pharmacokinetics, physiological changes in pharmacokinetics that occur during the first 12 months of age. And so we've got to understand what is happening to the drugs that we are giving to these children. And there are clear guidelines, albeit, and I'll show that in a little bit also, there's differences in opinion on that as well. Changes in the dosing of drugs for infant ALL. All right, so ALL. So I'm going to start back on Interfant 99, which was really the first big international ALL study that was done. I'm not going to go into details of the protocol itself. There was a prednisone prophase, and I'll show you that prednisone prophase was a very, very strong prognostic indicator in infants as well. All right, and then they went through an induction. We'll talk about the induction as well a little bit, how it was slightly different, and then intensive consolidations, and then went on to maintenance in there. Patients with high-risk disease had the option to go on for stem cell transplantation. All right, so this is again the schema of the induction. One of the things that's really important is this addition of cytarabine. Infantile ALL, KMT2A rearranged ALL cells have an increase in the receptor that cytarabine binds to and is internalized. And therefore, based on that, so there's an increased expression, cell surface expression of that receptor. And so based on that, there was a presumption that addition of cytarabine to the induction protocol of the ALL patients would be beneficial. There's no randomized trial that was done that with or without this. So there's no head-to-head comparison that we can use, but this has just become a standard of care for this. So it's been used not only by the Interfant, but also, as you can see down here, by the Japanese group as well as COG. What I was talking about in terms of pharmacokinetics, what you can see here is both the Japanese group and the Interfant and COG have different criteria for full dose versus 25% dose reduction versus 33% dose reduction. And it's different ages in there. So there is a discrepancy in here because the pharmacokinetics is a little, people I think are a little unsure about exactly what the pharmacokinetics here are. But what the take-home message really here is that there is a need for dose reduction for the younger infants because their ability to handle the drugs is different. And they tend to have much more toxicity. So what happened with this? Well, there was an overall survival of about 50% with a event-free survival of 46%. Age in terms of months was very, very prognostically significant in univariate analysis as well as on multivariate analysis, as was the MLL or KMT2A rearranged status in there. Prednisone here was also shown as the prednisone response. The first week, the prednisone prophase response was shown as a clear prognostic indicator here. And as you can see in this particular group, patients were categorized into high risk, intermediate risk, and low risk, group 1, 2, and 3, based on presence of MLL gene rearrangement or KMT2A rearrangement, age, and white cell count. And as you can see that there is a clear relationship between the grouping, the risk grouping, and the outcomes for these patients. So in the Interfant 06 protocol, the induction remained the same. However, what was tested was this, which was the addition of an AML induction phase, induction and consolidation phase, instead of the standard protocol 1B consolidation. And this was again based on observations of myeloid-associated markers that are very commonly seen on infant ALL, leukemia cells. Excuse me. The patients were again grouped into group 1, 2, and 3, with group 3 being intermediate risk, group 2 being high risk, and group 1 is KMT2A germline. And the results were almost exactly the same as Interfant 99, approximately a 50 to 60% overall survival and a 40 to 50% event-free survival in here. The difference between the low, medium, and high risk was almost the same as was seen previously. One thing that was very interestingly seen in here, was that those centers that had participated in Interfant 99 had better outcomes than those centers that were new in this Interfant 06 protocol. So there was some effect of sort of a learning phase in here as well. So this was an interesting finding that they had in there. Prednisone prophase continued to be a prognostic factor within here. And again, as you can see in this one, when they compared the two arms in the high-risk group between the AML type consolidation versus the ALL type consolidation, there was absolutely no difference in the outcomes in there. So what about stem cell transplant? So on this protocol itself, the 6-year event-free survival for the 164 patients that in the high-risk groups was 20.9%. Very, very low. All right. 143 achieved CR, but only 76 made it to transplant. And that's because 50-something of them relapsed before they could get to the transplant. So very early, very rapid relapses occur in these patients. Of those who actually went into transplant, 44%, the disease-free survival was 44%. So slightly better than everybody else, but maybe that's just the biology of the disease. These were just a biased sample. So these were the ones that actually made it to transplant and not the 50 who did not make it to transplant, who had much more aggressive disease. So whether it's beneficial or not, I'll leave it up to you guys. Okay. From June 2009, stem cell transplant was also recommended in the medium risk group here who had positive MRD at the start of Octadad, one of the consolidation protocols, the fourth one. So out of 23 patients in this group, 16 received stem cell transplant, and they had a horrible disease-free survival of less than 20%. So again, not just within the medium risk group, also you can identify by MRD, you can identify a subset of patients that are going to do really, really bad, regardless of whether you transplant them or not. All right. So after all that bad news, we'll come to some good news. Now, Dr. Samina has already set the stage for this. So this was the first study that actually looked at Blina in terms of its efficacy. And this was really a retrospective real-world review of Blina for infant. And they went back and looked at all the patients around who'd received Blina, and they identified these and, And you can see that all of these were really, most of these were really in CR2, some had refractory disease. There were a couple in CR1, but with positive MRD. These guys all got Blina, and most of them achieved a negative MRD level. Right. And several of these actually achieved complete remission at the time of the study. And you can see the outcomes of these patients. So these are patients who would have had a outcome, as I showed you earlier, of less than 20% because they were MRD positive, or were refractory or were relapsed, but actually were able to achieve a 50% event-free survival. So what was presented earlier, this was a paper published just last year by Lewis et al. 30 patients were enrolled in this from over a 3-year period from 12 sites in 9 countries. Blina was added just post-induction in here. And again, on this swimmer's plot, you can see the purple really shows patients who are in continuous remission. And you can see that a lot of these patients are in continuous remission. A couple of patients have relapsed. These little stars that you see over here are relapsed patients in here. And these are some patients that were transplanted. These are the high-risk patients that were transplanted, a couple of medium-risk patients as well. But even these patients, having received blina, undergoing transplant, are in continuous complete remission. And so the survival for this one, the 2-year disease-free and overall survival, is remarkably different from what we've seen earlier with the Interfan studies. And again, what you can see is when compared to the Interfan studies, this lower graph is the historical Interfan group. And this is the one, this current study that was just published recently, shows a significantly different outcome within there. What about CAR T cells in infant? And again, this is a real world use of I don't even want to say this, but CAR T, it's a CD19 CAR T cell in infants. And again, this swimmers plot shows you that there is, so all patients received the CAR T at this point in time. 4 patients actually developed myeloid transformation. And so this is something that one has to be careful of. Myeloid transformations were also seen with blina. So some patients were non-responders, others were responsive. So really those that had response did better with CAR T cell than those that were a refractory disease in there. All right. What about novel agents? What's new in this thing? So besides just immune therapy, what else is there that we can utilize? So ALL, infant ALL cell, KM2A, rearranged in cells also express FLT3. So FLT3 inhibition with lastartinib was used. However, there really wasn't a big difference. The event-free survival was 36% for lastartinib versus 39% with chemotherapy alone. So really didn't work. Demethylation. Again, there's a lot of methylation that happens in here, and there was a suggestion that demethylation might work. So azacitidine was used, as is effective in MDS, for example. And here again, event-free survival was 34%, no better than historical controls. And you can see that in this little Kaplan-Meier over here. KMT2A rearranged cells also express BCL2. So venetoclax, which is the BCL2 inhibitor, a targeted agent here, which is used in lymphomas, was utilized here as well, and again, did not show any great efficacy. There is, though, a trial underway right now with venetoclax in addition to blina, that we'll see if those two together will have a better effect in there. So in conclusion, these kids, KMT2A rearranged ALLs, have a horrible outcome. Standard chemotherapy regimens and stem cell transplant really has not shown any significant effect. CD19 directed immune therapy, whether it's with blina or it's with CAR T cells, seems to have a positive impact on outcome. But we've got to see how this is incorporated into the protocols itself. And really what we've got to do is we've got to have a better understanding of the drivers for this leukemia and see whether we can actually identify something that can be used as effective targeted therapy. Thank you.
Thank you very much for keeping really, really on time. So we go to the third talk on our final session before lunch and namaz break. So, and this is going to be a virtual talk, and this is by Dr. Oena Mercy Denneker. I hope I'm sounding it right. And she's the program director and clinical lead for pediatric stem cell transplant at Bristol Royal Hospital for Children in United Kingdom. She's working as a consultant in the pediatric stem cell transplant since 2019. She has done a PhD in the field of stem cell transplantation, and she's been a principal investigator and a very ardent researcher in participating in numerous trials.
Hello, can everybody hear me right?
Yes, we can hear you.
Thank you. Thank you for the kind introduction and for inviting me to your national symposium. It's a pleasure for me to present some of the updates for indication for bone marrow transplant and cellular therapies. Let me see if the slideshow goes well. Immunotherapy procedures have had an incredible progression from the start of these treatments to date, from initiating the allogeneic procedures in the late 60s to developing targeted immunotherapies, such as tumor infiltrating lymphocytes in the 80s, and starting to understand in the 90s the importance of graft versus leukemia and the donor lymphocyte infusion role, in addition to chemotherapy for achieving cure to drugs, to achieving a cure, to developing drugs such blinatumomab and checkpoint inhibitors, to developing CAR T cell therapies and gene therapies. My next slide, I think, is gonna show the very fast progression from one thing to another, and hopefully will continue to grow and develop and make all these procedures available worldwide for the entire world. I'm just going to present some of the history of how we started. And the first description of cancer was in 1600, but then there was a very slow development with the first blood transfusion for a patient with leukemia in 1873, while the major discoveries are starting only in the 1900s, in combination with treatments that we are still using at the moment and we are still recognizing. I just want to mention just a few of the pioneers in the field, with the first transplant for severe combined immunodeficiency led by Mortimer Bortin, and Santos leading on treatments to prevent graft versus host disease, with significant breakthrough in HLA systems by Dosset and Matte, showing the first human chimeras, which we know is so important for us. Don Thomas being in charge of the first successful allogeneic bone marrow transplant in leukemia and aplastic anemia. Now, the initial results of stem cell transplant have been very, very poor, with very low survival rates. As we know now, this was explained by significant levels of mismatch that people weren't aware of because they didn't have the tool to investigate that, which was triggering graft rejection and graft failure, and GVHD, less advances for supportive care, toxicity, significant toxicity linked to conditioning and infection control issues, just to mention a few of the issues. Nevertheless, progress was made with understanding the importance of the stem cell sources, donor-recipient matching, the fact that developing a new immune system and starting to have some better outcomes, with Don Thomas, the father of bone marrow transplant, winning the Nobel Prize for delivering and developing bone marrow transplant, and starting, as I said, understanding the importance of the immune system in curing leukemia, developing the new techniques with using very high doses of chemotherapy and using donor cells to salvage the recipient, to develop an immune system that would maintain the remission achieved by chemotherapy, was just at the beginning. Next, I'm just gonna mention the bone marrow transplant indications that initially were focused on cancer, in leukemia in particular, but nowadays there are so many different indications, and these tables are just showing the variety of transplant indications that we have in the UK, standardized and in guidelines. For the sake of the time, I won't discuss this in details, but I'm happy to take any questions if we have time. I'm just going to mention one of the work that the group in the UK has done in terms of novel approach in terms of transplant, and the UK group has published recently this retrospective study that indicates that T-replete core transplants give superior outcomes in high-risk and relapse-refractory pediatric myeloid malignancies. This is achieved by proactively promoting graft versus leukemia by an early cessation of all immunosuppression, like by day 40, day 50 post-transplant, all this immunosuppression is stopped. But also being able to manage the associated complications with that, hence a experienced transplant center in managing core transplants is essential for this. There was no evidence in this published data of increased risk of chronic graft versus host disease in this setting. I'm just gonna remind everybody about the impressive work that Inborn Error Working Party has done to put together a list of conditioning protocols for inborn error immunity diseases, where the conditioning intensity and levels of required donor cameras is very variable and dependent on the diseases that require an allogeneic procedure. It's the need of finding the correct balance of the right level of chemotherapy to achieve the right levels of donors and minimize the associated short and long-term toxicities. As there was and is a continuous search for identifying novel targets and less toxic therapies, the CAR-T activities appears to be growing everywhere in the world. This is more accurate for the adult field than the pediatric field, where the trends haven't changed as much. As we can see in this slide, most bone marrow transplant indications continue to be for the myeloid diseases, where the cellular therapies still fall short. There is no efficient CAR-T for myeloid diseases, as I will present in the next few slides. In terms of advanced cellular therapies, I will focus mostly on CAR-T and gene therapies, but wouldn't be fair to miss the importance of donor lymphocytes infusions, particularly for myeloid diseases, when we try to revert back to full donor if we see a drop in the donor levels post-transplant, but also cellular therapies for graft versus host disease and for viral infections. So next, it's just a bit of introduction to CAR-T, which I saw my previous speakers introduce that to you, so I'm not going to talk too much about it. Characteristics of an ideal target for CAR-T therapy is to be expressed in majority of patients, have expression in all malignant cells, not to express in healthy cells, can be targeted with CAR-T cells, not expressed on T cells, to be functional, relevant for cancer cells. We all know how the CAR-T are looking like. We have 4 components mainly, and we know we went from more simpler versions of CAR-T, and we developed going to third generations. Here in this slide is just briefly showing the progression of developing of the CAR-T products, which have started in 2011, 2012 in the United States. We all know the New York publications about the first patient receiving CAR-T. And the stages of approval, which take a long time. In particular situation here is we're describing the Kymriah process. In the UK, I was lucky enough to be part of the teams developing the CAR-T in London, in Great Ormond Street. And I remember the excitement in the team when moving from one type of CAR-T to the next CAR and having better outcomes and better safety, better efficacy with the new products that are coming our way. The work was led by the groups at UCL and Gosh with Professor Amrolia and Sarah Gorashian and Wasim Kasim, who is still inventing beautiful things in this field. In this slide, we can see that the number of patients treated with non-hematopoietic stem cell cellular therapy is continuing to take on, and DLI is still important. In terms of CAR-T, we see that on the adult side with myeloma indication and non-Hodgkin lymphoma is increasing year by year. I think we have a variety of CAR-T at the moment with different ways of producing this CAR-T, but the access to these products is not the way it should be, and is very focused on North America, Europe, and Australia. So I think we all need to advocate as much as possible for these products to be made in a way that are cheaper and more accessible for everybody. Now, just to mention a few types of CAR-T, as you all know, CAR-T for BAL is the starter, is the what started this treatment. So I'm not going to go into much details, but we have the CAR-T for CD19 positive ALL, for CD19 CD22 combination, but we also have the UCAR, universal CAR-T, which is from a donor, and it's available to access the vials immediately. However, this type of CAR-T will need an allogeneic transplant afterwards. So it's still ongoing to identify the best way of offering these products. It is a challenge in terms of maintaining the persistence of CAR-T, and there is a lot of work looking in how that can be managed in a better way. And also in the UK group, there is some maintenance therapy offered for selected patients for early loss of B cells, aplasia after CAR-T, to understand if these patients could avoid allogeneic transplant. There is also development for CAR-T for TALL. As we know, TALL is a very difficult disease. The outcomes with standard allogeneic transplant are not brilliant. So there is work, and Great Ormond Street in particular, on developing this type of CAR-T that is followed by a transplant, and it's still in a clinical trial stage. In terms of CAR-T for AML, there are many issues. There is no groups that have shown good results so far, and there are some identifiable targets, but it's still work in progress, and it needs to be made more selective, because unfortunately the targets that are presented in AML are also presented in healthy tissues. There are multiple different trials ongoing, but as I said, there is nothing very successful to date. The most common targets being CD123, CD33, CLL1. There is a significant myeloablation coming with this CAR-T that needs to be understood if it's safe. And there is a cytokine release syndrome, which is similar to all the rest of CAR-T, but there is rarely neurotoxicity. There is future ongoing research that it's vital and it's ongoing. There is other avenues for CAR-T. Once you have the technology, this can be applied to different diseases, and hopefully will expand and will include more and different indications. Autoimmune diseases, myeloma is already ongoing, Hodgkin, and other diseases. As I mentioned, there are many products, there are many indications, and just watch this space. I'm sure it's going to come our way more and more. Next, I'm going to just go into gene therapy a little bit. In terms of gene therapy, the recent and perhaps less recent developments in terms of developing technologies enable site-specific gene editing and safe and efficient gene transfer that has broadened the diseases for which we can offer gene therapies. Research and findings in the differentiation of paths for multipotent hematopoietic stem cells, size and replication rate of human stem cells, and the role for distinct populations forming the cell reservoir after transplant has enabled researchers and clinicians to apply cutting-edge technologies to offer safely novel and potentially less toxic therapies in an all evolving and developing field. Just briefly to show the phases of gene delivering systems with the vectors that are available, with the main therapeutical modalities summarized in this busy table. We have retroviral vectors to lentiviral vectors, design and nucleases and different types of editors, all with upsides and downsides that are in need to be assessed for short and long-term safety and efficacy. Gene therapy uses autologous stem cells, which is a positive, of course, because that takes out the requirement of finding a donor and eliminates the complications associated with all allogeneic procedures. But also, in order to achieve stable engraftment of transduced cells, conditioning with chemotherapy is still required. However, the intensity of conditioning is dependent on the level of vector numbers required for cure. Hence, a high vector number is required for cure, then a more intense conditioning will be required. For example, in the cases of diseases where the brain barriers need to be passed, the vector numbers need to be high, and it's essential then to have more chemotherapy, more ablative chemotherapy, and that will come with similar toxicities that we have with allogeneic stem cell transplants. Hence, a disease-specific biological background and the therapeutical transgene levels, as well as the principle of transplantation, are required for selecting the correct gene therapy and conditioning with overall enabling expert patient care. A brief scheme of the gene therapy process is just shown in this graph. Going through indications for gene therapy, as you know, they are very dynamic and continues to open for new indications. Inborn error of immunity has been one of the first indications looked at, and in terms of gene therapy, particularly for adenosine deaminase deficiency, which is a rare and life-threatening severe combined immunodeficiency, but not only for ADA, but also for CGD, for Wiskett-Aldrich syndrome and other SCID, which would have significant toxicity with allogeneic bone marrow transplant and lower success rates. As proved in this study, where 50 patients from United States and the United Kingdom underwent gene therapy with cell transduced with lentivirus. At 24 months, all the patients were alive. They were event-free up to 96.7%, excellent results. And if this can be applied to other diseases, that will be absolutely marvelous. In terms of benign hematology, we have gene therapy offered for sickle cell disease, Fanconi and beta thal, and which are starting to come out of clinical trials and be available in clinical practice. This is offering a cure with less toxicity compared to allogeneic stem cell transplants to patients that otherwise would have significant blood products treatments and associated complications, to only name a few, in addition to all the transplant-related complications that we all are aware of. There is some research looking into gene therapy for malignant diseases, in particular solid tumors. This is still in clinical trial stages, and the safety and efficacy needs to be determined. Other indications for cellular therapies would be for neurodegenerative diseases, such as ALD, which so far shows good results, but additional follow-up is required to assess fully the duration of response and long-term safety. Metabolic diseases are another growing field for gene therapy. Now, there have been some covers regarding potential cancer risk after gene therapy. The viral vectors can trigger deregulated pre-malignant cell proliferation with unexpected frequency, most likely driven by the activity on the gene promoter. work on promoters being more specific and use of a less broad promoters appears to be safer and with less risk for myelodysplastic or premalignant proliferation. So far, most cases described with MDS or leukemia features in the cases of gene therapy proved not to be linked to the gene therapy and the vector used, exception being one case. Another therapy that's coming our way is gene editing, that is cutting edge modality to enable gene therapies that may avoid problems associated with gene therapy, such as vector related mutagenesis and dysregulated transgene expression. This would be gene repair by either CRISPs or other gene editing technologies. These are looked at for immunodeficiency and benign hematology at the moment, but as soon as the process is proved to be safe and efficient, there will be an expansion for broader indication, hopefully. Thank you very much. I hope I haven't exceeded my time too much. I'm happy to take any questions.
Thank you very much. That was a very, very enlightening and a superb kind of wrap up of what is happening on the front of CAR T cells as well as gene therapy. So we come to a closure of this session, but before that, we will have our speakers come for the Q&A. Dr. Asim, Dr. Samina, and Dr. Denekar is available online. Do we know if we have questions online? Yes, please go ahead, Dr. Mary.
Thank you very much, Asim and Sabina, for talking so eloquently about novel target treatment. So I think we've been doing it, and I think that's part of our standard protocol on the NHS and standard indication for patients who have a lot of toxicity in induction or inhalation. And then it's also standard in relapse patients where after they've been able to achieve that 2-week induction with inhibitor, the type of thing last in ALM before MRD they given really good example of I was going to ask you, in terms of health economics, Linda in the long run is much cheaper. The RP protocol that we need to use for relapse patients is so costly. Patients will stay there for weeks and weeks. So this is horrible to watch, but Linda has revolutionized care on that prospect that it's very much less toxic. They have their pumps, they need about a month of treatment, but with proper sort of organization and supervision, it's a much less toxic protocol. So having looked at that and seeing whether it could become part of frontline protocols, which is really the future.
Well, you know, the recent COG study that just closed, you'll probably see the publication on that coming out next month or the month after. I think it's being submitted to NEJM. And that shows this was with 2 cycles of Blina, one immediately after induction and the other one just before delayed intensification. And that has shown a significant reduction in relapse rates in high-risk patients as well as in standard risk patients. And so this is actually just about to be published. And so this is really going to revolutionize the way treatment is given. Now, first, this was addition to standard backbone therapy. And I think as we move forward, what is going to happen is that there's going to be phase 3 studies that are going to look at replacement of standard backbone elements with Blina itself. There are several issues that you point out, particularly regarding the cost. Now, Blina sort of has the honor of being in the top 10 expensive drugs in the world. It's number 9. We were just looking at it. So So that's there. And what this does then is, so that's one issue. So what it does is that it sort of widens the gap between HIC affordability and LMIC affordability, right? Especially when you've now got Blina coming in as standard of care for frontline therapy, right? So that gap continues to increases in there. You're talking about the availability, the facilitation of it. Yeah, you put them on a pump and you send them home. That also cannot be done in LMIC because where is home, right? And so there's a lot of issues that need to be tackled before it can be done. There's another issue that I just learned about is that Amgen may not be able to produce as much Blina as is required for ALL therapy across the world. So again, you're going to have sort of a embargo on, like we did with the COVID vaccines, right? We're going to have an embargo on Blina availability to certain countries and not to others. So I think there's going to be a lot of very interesting conversations that are going to happen soon. Oh, it's brilliant as a drug. You know, we've been using Blina because AKU has been part of the
Amgen.
the Amgen Access Program. And so we've been getting Blina for our patients free of cost through Amgen St. Jude association that we there. And we've actually had a very, very good experience with it. So yeah, that's there. But so again, even within LMIC, then we are coming up with these socioeconomic limitations in terms of who can get it and who cannot. Yes.
And in health economic terms, for the future of NHS, we have to think about this. So they have worked out that top is therapy, all the hospital stays, the other therapy, and is cheaper, really cheaper than the long.
Yeah, and I think the cost of Blina will also decrease because as it starts to be prepared or developed, hopefully in bulk for all ALL patients around the world, then hopefully the cost will come down as well. But even if it comes down right now, it's what? It's each vial is about $7,000-8,000. And with it for a 28-day course, that's over $100,000 or several $100,000. You have to think about the whole thing within it, yeah. No, it's a brilliant drug. It's an
Yeah.
absolutely brilliant drug.
Yeah.
Yes.
It will be hard for everyone if they have to run on the.
Yeah, yeah.
So that might be easier to get in.
Yeah.
Just an update on that. I was just at the COG meeting last month. And the trial that was running with the Blina with the standard risk, I think that COG is declaring it one of the most successful clinical trials that have happened through the 25 years, or 25 years going to be next year for COG. So the amount of benefit that they got from the Blina, so they have now stopped the trial and actually calling back patients who did not get it to get the Blina. Because there was so much of a difference for the standard risk. And now they're going to open it as, so Blina is going to be upfront chemotherapy, which is now, I mean, this is going to be a breakthrough in the management of leukemias that, change in management of even standard risk layer. So they are talking about that. But on the other hand, there are some groups that are worried that if standard risk upfront gets Blina, and if they relapse, then what are we? We have nothing else to offer them. So they are a group and and of course, all the issues of availability and all that. So there's a group that is extremely happy and ecstatic that this was a very successful trial. On the other hand, there are these issues that people are, we still have to worry about what is going to happen. And overall, I think for low middle income countries, we are way far away from getting this as for upfront availability for our patients. So that's going to be a challenge for us.
And again, this is a newer drug, so maybe 10, 15 years, we may have a bigger data on that aspect.
So I think there is an incidence of in infants there was an incidence of myeloid transformation. In ALL, in non-infant ALL, there with blinatumomab, there is a very small incidence of CD19 negative progression. But it's not as much as the benefit that you get from it. In our own experience at AKU in Karachi, how many have we treated so far, Zahra? 20.
We have about around 14,
Yeah.
14, 15 that we have
And
treated.
I think 2 of them actually had CD19 negative progression.
Negative progression.
Right. So it is there. I mean, this is 2 out of the 14. But
I think our fellow is presenting our experience here in the post. He has an oral poster of oral presentation, which will be tomorrow, of our experience with Blina.
Very honest, what we are using, children are literally enjoying it because we don't send them home. We don't have home services. 28 days they're in hospital, no nausea, vomiting, no fever, nothing. They're much happy compared to their usual chemotherapies. We give regular paracetamol or painkiller for 2 to 3 days because most pain and everything are coming first 2 to 3 days. We keep them and they're very happy because they don't get usual side effects of chemo. We even in UAE, it has been a standard of care, but we are not offering to all the families because there are too many insurance issues there. We are only offering to the local families. We are not even talking with the families because creating a lot of anxiety in the parents that we cannot arrange it. So we only talk with the local families, or as they discuss severely fungal infection, or these are the things. But children are happy with it.
So I think the ethics of this is going to be quite.
Yes.
There's going to be
Yes.
a lot of discussion on the ethics of this. They cannot have CAR-T either. Yeah, because that's a clonal progression, right?
The
Yeah, CD22, and that's coming.
is there a question? There is this question? Oh, yes, I had a question for her. Dr. Denekar, I hope I'm mispronouncing this.
Call
Fine.
me Wana. Wana is easier.
My question is that I think there's a lot of debate about, doing transplant post CAR T cells, to do or not to do. And do you wait for the CD negative to resurface and then do it, or you do it before, or you monitor? What would your opinion be?
It's an excellent question, and it's still an ongoing look at, basically. So what we do, because of the data, is clear. If you have early loss of CAR persistence before 6 months, your risk of relapse is there, and it's highly likely the relapse will come your way. So what the practice is in the UK is to go to transplant. If you have early loss of CAR T, transplant will be offered. Now, the issue here is with the infants, and when you can't offer a TBI-based conditioning, which raised the question of what to do. Hence, the maintenance came in, trying to initially keep that disease under control while you don't have frank relapse. You don't have flow relapse. It's very ethically challenging because you put them on maintenance thinking the leukemia will come, but you're trying to keep it going in remission as long as you possibly can to be able to offer the right, correct treatment. As we know, leukemia, acute lymphoblastic leukemia at any type, to have great success rates, you need radiation, you need TBI. That's the challenge we have now with the young ones. And I know that Christina Peterson and the group in Santana in Vienna, linked to other groups in Europe, are looking into doing forum 2, forum 3, where they are looking into offering lower doses of TBI for younger patients. So it's debatable indeed. At the moment in the UK, if you can offer TBI-based conditioning and you have early loss of CAR T, the recommendation is to go for transplant. If you are younger and you don't have the option of doing TBI-based conditioning, then you go through many national entities and go through many talks to decide what to do. And we take into account the parents' wish. If they want to wait, they take that risk of waiting and having full-blown relapse and then go to transplant, or just wait and be on maintenance. They might not ever relapse. So that would be an interesting data to come out after longer follow-up. I hope that answered your question.
Yes, thank you so much. That is very helpful.
If I may
Actually-
add on the blina discussion, blinatumomab has changed the picture of treating ALL, as my colleagues just mentioned. And it's an excellent drug to bring people to transplant in a deeper remission and with less toxicity. What we observed in the UK, and we're going to present this at ASH this year, is that we've seen a lot of mixed chimerism post-transplant, and particularly the people who had significant drop in chimerism in the first 6 months to up to 12 months post-transplant. We are very concerned about what that means, because historically we see more relapse when you have dropping of the chimerism. But we are just trying to understand if this is blinatumomab-based, less intense chemotherapy pre-transplant, how is that changing the alloimmunity post-transplant and all that. Nevertheless, the results, even in mixed chimerism, and keep it secret, it's not out yet, it's still better with blinatumomab compared with a standard chemotherapy. So definitely blinatumomab is here to stay, and it's gonna continue to do great things for people.
Yeah, totally agree. And I mean, our experience also with Blina has been really, really good.
So to answer you, Shazia, I mean, we have done less than 20 patients. Shazia, you were asking about the side effects. So we acutely, the only serious side effect were the seizures. And that also they were controlled within 48 hours, and we could reassume the Blina. And one patient was like beyond was the neurotoxicity grade 4 that we had to abandon. But for overall, there has not been any major side effects that we have noticed. The first week is like challenging because that's the first time, and CRS and fevers, and that's once we're over that 1 week, the rest of the infusions have been just the patients have just sailed through it. I think that's like a long-term thing that people still need. We still need a lot of information on that. Yeah. Thank you very much. This was a fantastic session. And so we break for lunch, but we have a picture. We have to have a picture before lunch and namaz break.
So the namaz break is at 1:30. So we'll just take 2 minutes to take a group picture. And I would request everyone to be back in the hall at 2:30. We've got the hall till about 4:30. Yeah, I've checked with the organizers, so we can have 1 hour lunch and prayer break. Okay, so everybody please be back at 2:30. Sharp is the word that I used in the past, but please.
Sharp.